This is a 46-year-old male who is currently hospitalized with idiopathic pancreatitis that was complicated by a formation of a pseudocyst. He was actually transferred here for cyst gastrostomy. This is the CT that shows the large pseudocyst near the pancreas. And we actually did the first US guided cyst gastrostomy on this patient 5 days ago, which showed 8 centimeter by 8 centimeter pseudocyst and the pancreatic body drained by cyst gastrostomy. And at that time, 3 double pigtail 7x7 plastic stents were placed in the cyst gastrostomy. And patient is here today for endoscopic necrosectomy as well as stent exchange into a metal stent. And we have Dr. Paneros and Dr. Benmoller.
Hey, hi guys, how are you?
We're good. We have Frank, Adam, Simone, and myself, John, so we're all ready for you.
The dream team. This is a patient who was, as Wujin said, was referred to us for a cyst gastrostomy, which we did earlier in the week. And I do want to thank the referring doctor who's actually here at the course right now for referring him over. We did a cyst gastrostomy, which was pretty uneventful earlier in the week, as I said. And it's a very fluid-filled cyst, not a lot of necrotic debris. And I'm personally very excited to have Dr. Binmuller here and show us the AXIOS stent, which I think is this is a perfect situation for that stent, as you guys well know.
John, what was the etiology of the pancreatitis?
It's a good question. You know, he denies heavy alcohol use, and he certainly wasn't drinking heavily before the episode. His LFTs were normal, his gallbladder, doesn't show any stones or sludge, so it's a little bit unclear. At this point, we haven't figured it out.
So what I've done is inserted the echo endoscope. I thought we can first I sort of have an echo here. I don't know if you can remove that, so I'm hearing myself. But I thought it'd be good to just look with the US and see what the cyst looks like at this point, and maybe collapse. If you have the endoscopic image,
we have endoscopic.
Yeah, now you have the endoscopic. So this is the antrum. I'm just pulling back, and you're going to see I'm going to encounter fluid here. There's still a lot of residual fluid in the stomach. So I'm taking it that the stents were placed pretty high up, because I haven't seen the stents yet endoscopically. But rather than spend too much time trying to suck out the fluid through the echo endoscope, let's now switch to the EUS image. Maybe we can have picture-in-picture, so the EUS large. And yeah, perfect. So try to get some of the air out so that we can see what's going on in the retroperitoneum. And here we are. You can see there's a decent cavity still. You can see some necroses in there. It's shadowing, right?
Yes, we see that very well. Very nice.
And we could even kind of freeze an image and sort of measure out. The necroses creates a lot of, maybe right there, yeah. So, John, why don't we measure out just sort of a cross-section here, just to get sort of an idea of what's left here.
Okay, I'm not seeing the stents actually endosconographically yet.
It's interesting. I don't see it yet either. Maybe they migrated out.
I was wondering about that, or we're just not on the right plane at this point.
So it's hard to say because of the shadowing, how deep this goes, but I think we can release now. And so it's about 3.8 we've got here. And that's just that one cross-section. This is liver. There's some cysts in the liver. Back to the retroperitoneum here. Okay. There the stents. You see them now. Right. They're close. And I think, John, you said there are maybe 3 in there? Or there are 3, yeah. So, and now we're seeing, this is actually looking more generous, isn't it?
Yes.
Right? A little bit larger. Now, there's several options. One option, John, it would be to actually, under EUS guidance, one could deploy an AXIOS stent right here, and you could leave the plastics as we can pull them out afterwards. That's one option. Other option would be to remove the plastic stents, and then we'll just insert the AXIOS through the port that you've already created. How far did you dilate to get those in, John?
We didn't dilate at all.
Okay.
I will mention that we needed a needle knife to puncture through
Yeah.
because it was a fairly mature wall. But we did not actually dilate at that time. In general, that's not my practice the first time I'm going into the cyst.
Yeah.
But what is your practice on that?
Yes, so the beauty of the AXIOS, it would be that you could now, ideally with a hot AXIOS, which isn't yet available, it has cautery integrated into the tip of the sheath, and so you can just burn your way right into the cyst lumen, and then immediately deploy the AXIOS stent. So the distal flange, snug it up, and then deploy the proximal, and you've got your anastomosis, if you will, and then you can dilate afterwards with your stent in place, and that way you can prevent bleeding and perforation and so forth. Otherwise, what I've been doing with the cold AXIOS, which is all that we have in the US, is to use a cystotome. Then you're going to have a 10 French opening. The sheath of the AXIOS stent is about 10 French, and so it's large enough to get the sheath in and then deploy. So you don't have to really dilate in excess of the diameter of the sheath of the AXIOS stent. So,
Yeah,
yes.
sorry to interrupt that. This is a great discussion, so I really want to hear that again, but I just want to show us something quickly in the other room.
Yes,
So when you guys decide what you're going to do, if you can hold on, we'll be back with you shortly.
sounds perfect.
Thanks.
So let's go in and look at
All right, so we just wanted to show you really quickly with the diagnostic scope what we have so far. So this is the pylorus. It's actually shortened down quite a bit. So it was 70 centimeters from the incisor, and now it's at 50. So we at least have a 20 centimeter reduction in that. So we're going all the way up, and you can see how here it's tied at the angulation, which is common in sleeves, but it's good enough for the scope so far. And then you're going all the way up. Here into the GE junction. We still have a little bit of fundus to work with, and so we're going to just try and pull this area down a little bit more.
Yeah.
So we're aiming for at least 50% volume reduction. Hopefully we'll get that. So you guys will come back to us hopefully in a little bit.
Okay. Was that second suture, the one you got stuck on, that was okay? The cinch fell?
No, actually the cinch malfunctioned in that one, so we repeated over it. I mean, the sutures were still there, but we just thought to get the results, we ought to just repeat over it.
Right. Okay,
It didn't
great.
really take that much time.
Yeah, we'll come back and join you. We'll just head over to Ken and, okay, thanks very much. Ken, we're back with you. John?
So Greg, I just inserted the gastroscope, actually a therapeutic gastroscope with therapeutic channel, of course, a larger channel. You can see there's still a good amount of fluid in here. There's also some solid material. I have not seen the stents yet. My concern, let's see how much of this is solid that may not be removable or aspirable through the working channel. In retroflexion, as you can see, we're getting a fair amount out here.
So
it's
do you
not-
think the stents may have decided to hang out in the cyst?
I hope not. But although that, as you just saw, we should have access to that cyst. It's still large enough.
It's going to be
Were
on.
the stents put in with the EUS?
Yes.
Now, and we've noticed at our place that I don't do EUS and I drain a lot of cysts and I use a needle localization technique. And when the EUS guys use the EUS, they're much more proximal
Yes.
than when I go in with a side viewer. And when you need to go in and do debriding and so forth, it's a lot harder to work high up in the stomach. And I wonder if that's been other people's experience because you're kind of poking down with the linear EUS scope that you end up much higher up in the stomach. Whereas when I just go in with the side viewer, I'm really at 90 degrees and I pick a site that's convenient for me to get into the thing afterwards. Is that a shared experience?
Absolutely, yes. And that's why it's so important that before you do your puncture with your FNA needle, that you endoscopically confirm where you are so that you're not up in the esophagus. And it's very easy to be mistaken. And what you're seeing is stomach, of course, but actually your needle's coming out in the distal esophagus or at the cardia. So that's obviously problematic when you deploy your stents. Well, it's problematically, firstly, because you increase your risk then of perforation complications, but also when you deploy your stents, now your stent's going to be in your esophagus and doesn't really have room to deploy. So the answer is yes. Would you agree, John?
I mean, I would agree that we tend to place them higher when you're doing EUS guidance. I think that you also have to recognize that there's a risk of bleeding, there's a risk of not being quite up against the stent as well as you'd want if you're doing it purely on an endoscopic guidance. If the patient has varices or portal hypertension and you're worried about hitting a fairly large vessel, I think EUS can be useful in that way. I think you also have to agree, though, that as the cyst collapses, that will also contribute to going back the second time and not being in the best position. So maybe what you're blaming on EUS guidance might be just that the cyst is collapsing and it has changed your position, kind of relative to where you put the stents in.
And to the point, look how high these stents are.
Yeah, this is right below the cardia, as you can see. So now we're talking about placing a metal stent, right? Whether it be a tubular metal stent like the Wallflex or another covered metal stent, or the AXIOS stent for that matter, even though it's shorter and so the flange is going to be flatter. But this is really close to the cardia here. In fact, you'd be a little worried that maybe the AXIOS stent, which has a flange, the diameter of which you'd be using a 50 millimeter lumen, you've got twice that diameter of the flange. You've got 30 millimeters, so that could actually block off the cardia here.
Yeah, I would vote for your plan of doing a separate puncture farther down. And then...
That's what we're going to do. I think in this case, definitely, because this is so high up here, I would be, number one, I'd be very concerned when you're this close to the cardia of aggressively dilating. Even if you have your stent in place and you're dilating through the stent, I would be worried when you're this close to the cardia. This is where bad things happen. So I'd rather be a little further down.
I mean, I will say that when we did it, it didn't appear to be that close to the cardia initially, and I think there was a lot of extrinsic compression. And now that the cyst has collapsed a fair amount, certainly we are a lot closer to GE junction than we'd like. Go ahead, Greg, I'm sorry.
No, it's the inherent nature of the EUS guide. It's a tangential approach. The old endoscope approach is more 90-degree angle, or you can achieve that more easily. It's just, I guess I don't know, the only question is the forward-viewing therapeutic echoendoscope better for not having that tangential approach? I've never used it, I'm asking.
And the answer is yes. I think that's where there's a big advantage of the forward view. I did have the opportunity to use the forward view, and you definitely get that more perpendicular for two reasons. Firstly, you can bend the tip of the scope in towards the wall,
Right.
perpendicular to the wall. That's number one.
I'm
So I
sorry,
need the
therapeutic
therapeutic EUS and the cystotome, please. So, and number two, of course, as you know, the angle, you're still at a slight angle, but your needle's coming in at a more perpendicular angle to the target. So
Right.
for those two reasons. And then also the fact that you have the advantage of really being able to confirm exactly where you are endoscopically before you do your puncture, or if you're in the case like this. This would be actually if you said, let's just imagine that cyst is decompressed, right? So you can't go for another puncture site. So you have to use the track that you have now. I think the forward view would be my instrument of choice if you wanted to do something with EUS right at the site where it was previously punctured, if you needed EUS. This would be an example where I think that would be helpful because you got limited space right there and you can really correlate exactly where you see the stent.
They have the forward view in EUS if you'd like. Would you prefer that?
I guess, yes, we could use it. Yeah, sure.
Okay.
Yeah.
And
So-
are you going to miss the lack of an elevator when you're pushing your stent through, or not really?
Probably not. I have to say I haven't used the AXIOS yet with the forward view because when I had the forward view, we didn't have the AXIOS. The AXIOS was just FDA cleared in January this year. So this will be, for me, at first, to use the AXIOS with the forward view. But no, I don't think the lack of the elevator would be an issue. I certainly didn't have any problems when I was using the forward view with the, for example, the tubular metal stents like the Wallflex. I didn't have any issues placing that with the forward view. So I think it'll be good. I actually think the forward view is an ideal scope when using the cystotome. Sometimes with the cystotome, because it's fairly rigid and stiff, it can be hard to advance it from the elevator. It can kind of hang up there. There can be some resistance, and it comes out at a very tangential angle, again, because it's very stiff and rigid. So with the forward view now, it's coming, of course, out in front of you. And you can also verify your position endoscopically. So since we're going to use the cystotome to create our tract, then I think it'd be very nice to use the forward view with this.
And question here, could you, now that you already have the opening into the cyst, could you just use a forward viewing gastroscope and under thorough control, use the AXIOS system without EUS?
Well, yes, of course you could. In this case, though, my only concern was, if you recall, we're very close to the cardia. And I'm a little concerned that the flange, it may block off some of the cardia because it's so high up.
Right.
If it were just a little further down, I wouldn't have an issue with actually, and that would be the easiest way to do it.
We're actually, because of the delay to get the forward view, we're actually going to just go with a therapeutic linear, if that's okay with the group. I'd be curious if you want to survey the crowd, how many people use EUS guided to do their cyst gastrostomies, and how many people use just endoscopic guidance with a duodenoscope?
First, let me see, how many in the audience, if you raise your hand, do cyst drainage? Let's see, keep your hands up. Okay, see them? Now, if you do it with an ERCP scope, keep your hand up. Okay. Both. Okay, it looks like probably 2/3 are doing it with the US and 1/3 are doing it with ERCP or both.
Okay.
Can you get the EUS image now? So we're just waiting on an EUS image now. We should have that in just a moment.
Frank, do you want to comment on what makes you decide whether you just use ERCP versus echoendoscope?
Well, your question was a little general, so I mainly nowadays will use EUS. I am very comfortable doing the entire procedure with endoscopic ultrasound. However, in the early days, we used to do EUS, mark the area, and then go down with our duodenoscope.
The only problem I've seen, I thought, sorry, they were talking about moving rooms here.
Just to get started.
I'll let you, can you hold off or just, well, let me see here. You're ready to go, right, Ken?
Not yet. We're still waiting on the EUS image. I think we got it now. Do we have it? All right, Greg, sorry that I have my back turned to you here, but I need to look at the EUS image in front of me. And what I've done is I've passed the cystotome down the working channel, and it consists of two components. There's the Zimmer needle knife, so the needle knife component, that's the inner catheter. It's 5 French, and there's a removable needle knife that we're going to be able to remove after we burn through the wall with this catheter, with the Zimmer needle knife. And after we're inside of the cyst with the Zimmer needle knife, we are going to pass a guide wire, and then we're going to advance the outer sheath, which has a 10 French, which is 10 French, and it has a ring at the tip. So it's going to create a 10 French cautery tract into the cyst. And you have the EUS image in front of you. You can see I'm a little further down from where the stents were, and on my endoscope I'm at about 53 centimeters. So I'm clearly more distal to the puncture site that we had before. Now if you look on the image at the very top, you can see sort of like a double tram track appearance. This is the catheter only. This is not the sheath. This is the catheter, which is 5 French. Now Holly is going to advance the Zimmer needle knife now out. Okay, and there it is.
Yeah.
Can you see it? Let me see, where's this?
We don't
Right
have the
here.
US image yet.
Oh, you do not?
No, well, they just switched to a fluoro, so
Okay, no, well,
let's
let's
go back to
don't-
the US.
Yeah, forget
There
the
we go.
fluoro for now. There's the Zimmer needle knife. It's been advanced, okay? So I'm going to step on the cautery, and I'm going to burn now through this wall. And I can tell you this wall is thick, and as you heard earlier from John, they had some difficulty. Just pure cut is fine. Auto cut is fine. Just put it on auto cut. Okay, so are we ready? Okay, so I'm pressing on the yellow pedal now, and I'm going in. No, not endo cut, auto cut. That's okay. We are endo. So there it is. You can see the catheter it's in.
Right.
All right, it's nicely in there. And now the next thing we're going to do, and if you can just kind of hold that. I'm going to try to, wait this way, please. Hold it just like that. Try to keep my EOS view the entire time. All right, Paulie, now what I need you to do is just remove the Zimmer needle knife. Don't remove the catheter, of course, just the inner component. And normally what we would do now is also aspirate some contents and send that off for CEA and amylase. Just the Zimmer needle knife. That's what Paulie's doing here. I don't know if you can see that on a camera view. She's pulling out the just the needle knife component.
Right.
And then, Paulie, what I'm going to have you do, why don't you attach a syringe and try to aspirate something. We may not get anything back in the syringe, but what I'm hoping to do is to fill the catheter with some fluid, because if we now push our guide wire down, we will get air inside of the cyst, and we want to avoid that.
Right.
And then, I'm sorry, what was your name again? Vern. So Vern here is assisting me in holding, this is also very important, this is a real team effort. Vern is holding the endoscope so that I can kind of keep my eye and I don't lose my position on EUS. Because every once in a while you can still see the bright line. Vern, just like that, a little bit counterclockwise. Okay, try to aspirate now, Paulie. You're probably not going to get anything back, and this, after you've aspirated, stop, and let's then put a guide wire down, a jack wire, for example, whatever guide wire you've got. It doesn't matter.
So Ken, now you gave the aspiration, and obviously you got a sample, but you were also mentioning you do like to put some fluid into the catheter?
That is correct. I mean, right now, if I put the fluid down or the guide wire, it doesn't matter. I will push air into the cyst, and some air is going to come out. You'll see that in a moment.
Right.
But that's okay. It's not a big deal. And we also have fluoroscopy to see the wire come out. I just love to keep the EUS view. See some of that air, the air bubbles coming out? You can still see very nicely on EUS. And John, why don't you mag it up just one on the EUS, just so we keep we really don't care what's below the cyst. And now on fluoro, we'll step on the fluoro pedal, and you should see the wire inside of the cyst. Do you see that?
Yeah, we've got an insight. We've got an excellent view of that.
Good. So you see that the wire is coiled in there. Paulie's done a great job. She already knows what to do to coil it inside that stop there, Paulie. And now, this is the tricky part, Paulie. What I need to do is advance the outer sheath while you're pulling back the inner catheter. Now, the inner catheter extends 10 centimeters from the tip of the outer sheath. You cannot pull more than 10 centimeters, all right? So it needs to be a 1-to-1. This is where the cystotome gets a little tricky. In other words, what you don't want is that inner catheter to come back too far, otherwise I'm just pushing over a bare wire. And then there's too much step off between the wire and the outer catheter, and you're not going to be able to burn through. I need that inner catheter to stay in place, but I can't advance my outer catheter without Paulie pulling back on the inner. And so let's go ahead and we'll start. I'm starting to advance, and Paulie's pulling back slowly. And you're looking, Paulie, just to make sure.
Greg and Adam, do you use cystotomes?
I have used them, but I don't use them routinely. I've been training. I've been doing my entry with no cautery these days.
Okay. All right, just to let you know now, I am right at the cystotome is out, the outer sheath, I should say, the 10 French. And so I am now ready to get my pedal back. And we're going to use pure cut this time. Please, no endo cut. So I want it to be just one continuous current. It's called auto cut, right? And we can see this both under fluoro or EUS. I just use EUS. But if you want to step on the fluoro pedal while we're doing this, that's fine with me too. Okay, are we ready? You're all hooked up? Okay, good.
And Ken, we notice you try not to move the endoscope away. You avoid
That is right. You're trying to
endoscopic image.
never, don't look endoscopically. That will throw you off. Okay, good. All right, so we're ready now? And I'm pushing through and I'm through. You see how I just got through?
Yeah.
I'm not even looking on the fluoro. I'm keeping my eye on the ultrasound, but you may have seen it on the fluoro. Did you? Did someone step on the pedal while I was doing that? I don't know. So anyway, look, we're inside. We've got our 10 French tracked. And now, Paulie, I'm going to remove this and you leave the wire in place. Do not remove the wire now, okay? All right, so now we're doing an exchange, just like in the RCP. And I'm going to keep my eye on this wire. And I'm pulling out. Okay, it's going nicely. And intermittently, you can step on the fluoro. Don't step the whole time on the fluoro, please. But if you want to intermittently step on the fluoro, but you know, you can see, I can see it beautifully on EUS too. I can tell when you're falling back too far as well. Okay, so just intermittently, little pulses on the fluoro so that everyone here in the room can still have lots of babies.
Just to mention that when you do have the 10-French cystostome down, if you're not putting an AXIOS in, if you're putting multiple pigtails, you can put extra wires down through there.
Craig, I want you to know that I use the Haber ramp.
That is-
Put it in those 7 French stents.
But this is a wonderful device. We're out now. This is a wonderful device to put 2 wires down. That is a big advantage of using the cystostome. You've got enough room to put 2 wires immediately if you wanted to place 2 pigtails. I'm holding this, and Polly is now removing the cystostome, and now we're going to feed the AXIOS over the wire.
Ken, would it help us maybe if you could give us a room view, like a full room view, maybe show us the
Okay.
device on camera here.
So, yes, maybe
Okay.
it's
If
just
you're
a
able
little
to do that.
difficult. Yeah. Let's. What's very important now is to take off the biopsy port valve.
We're not seeing anything, if you get the camera
Right, I know.
close to you or what's
So let's see how we can do this, because the camera is to my back. That's why
I
it's
see.
tough. Look, why don't I'll show it to you afterwards, maybe.
Yeah, sure, get the job
Yeah,
done.
I'm sorry. It's just hard for me to turn around so that you could see it.
I don't want you to lose access.
Yeah, ideally, the camera should be in front of me. That would be a better setup. But, so that's why you're having to look at my back the whole time.
John, maybe you could show us the device,
Sure.
maybe hone in on it.
Can we get a large room camera now, view for looking at the device rather than the insert? That's great, thank you.
I certainly don't want to accidentally deploy it while I'm playing the
It shouldn't. That's why you've got that safety pin on there. There's a yellow safety pin, and they're locks. So nothing can happen. It's all kind of idiot-proof.
John, you should appreciate that.
I am appreciating it.
All right, so you'll see this, but there are 2 hubs here. This one hub is to advance the sheet forward, and then there's another hub up here to deploy the stent, and you can deploy the distal flange independent of the proximal flange. By just pulling up here, it deploys the distal flange, it clicks into place, and then by pulling all the way back, it deploys the proximal flange. So 2 hubs, this is to advance, this is like the FNA needle, right? When you advance your FNA needle, this is advancing the sheath part, and then this part deploys the stent. The stent is already preloaded, there's a bougie tip on there, a little nose cone at the tip, it's finely tapered, and the difference between cold AXIOS and hot AXIOS is that the hot AXIOS has little cautery wires at the very tip that run around the tip and are circular at the very tip, and it will create a very clean cut so that you can enter easily into the target lumen. All right, so we're going to advance this now over the guide wire.
Thanks very much, that was a great description.
And what I'm going to try to do is when I deploy the stent, hopefully the camera, I'm going to try to move such that, and that won't be as critical for me in terms of my position. Hopefully I'll be able to show you. You just hold it just like that, yeah. Just try to keep your eye. You can see the US image there, and you can see that bright white line running through. I'm trying to keep that. All right, so now this is no different than an FNA needle. We're advancing this through the working channel. It's going very smoothly down, and Polly knows what to do. She's pulling back the wire, but not too far. And intermittently, Polly, you can step on the floor just to make sure your wire's not coming back too far. It shouldn't be. One of the things I did forget to say is that we usually pan the sheet, but it's not a problem. I have no problem attaching this. The next generation will actually have a hydrophilic coating on the sheet, and so you just need to lubricate it with some water, and it makes it very slippery. All right, now I don't know if the camera, I don't see the camera, but I don't know if the camera can zoom in just for a quick moment on this handle part, so that you can sort of see this, and in the background you'll see the EOS as well. Are you able to see this here?
Yeah, we can see the handle nicely. The
Excellent,
camera's on that.
okay. So the first thing I'm going to do is unlock this here, right? So unlock, and this is to advance the sheath forward.
Right.
All I'm doing is advancing the sheath. Okay, so
Shoot
now,
over the wire.
right, over the wire.
Elevator down on the...
The elevator is now opening, and I'm pushing through. You see it just popped through?
Beautiful.
Do you see that on the EOS as well?
Yeah, we only see the EOS.
Okay. Only see, but you don't see the camera view.
No, we got the camera in there, but then we don't have fluoro, we have
Okay,
the
good.
EOS.
So now I'm in, now I'm locking. See, I've locked the sheet, so the sheet doesn't move.
Gotcha.
All right, now see this little yellow safety pin?
So Ken,
Take
before
that
we-
off.
one quick question. Is there a distance that you want that sheet in before
Yes.
you start advancing the stent?
Yes, it needs to be 2 to 3 centimeters in.
Is that
To give
marked,
yourself a little bit of room.
is that marked on the shaft to indicate the minimum distance to me?
It's sort of, my eyeballing it like this.
Okay.
Okay, all right, so I think it's in far enough. Now I'm going to unlock the proximal hub, the upper hub.
Just move a
There's
little
a
bit to the
lower
left
hub.
to get it in camera view. There,
Okay,
perfect.
lower hub, upper hub.
Right.
I've unlocked it. See the unlock?
Got it.
Okay, now I'm just going to pull this back. Now look on the EOS image
Yeah.
and see what happens. I'm just pulling back, pulling back, pulling back,
Beautiful.
pulling back, pulling back. You see the stent deploy?
Yeah.
Do you see how it's like a disc? Looks like a spaceship, right? A big disc there?
Yes.
Okay, now I'm going to switch to the endoscopic view. Now, the way we're doing this now is we do the full thing under EOS guidance. But when you start, I think it's better to learn it in 2 steps. This is deployed under EOS guidance. This is not going to pull out. So you can switch to an endoscopic view and deploy the proximal flange. However, when you're more advanced, like you are, Greg, well, you could just take this, snug this back, pull the sheath back until that disc takes on the shape of a football. And this I credit Alberto Lari, because he taught me this. He said, no, there's no need to switch to endoscopic view. So, hopefully I did his accent correctly. You can just snap back until it looks like an American football, and then you can deploy under EOS guidance the proximal flange, and it deploys perfectly.
So, yeah,
Let's do it under endoscopic now. So let's get the endoscopic view large, please.
Now, Ken, you could do this without a US under fluoro guidance, couldn't you?
Yes, you don't want it. And in fact, I do all of these without any fluoroscopy even available to me. So let's get some air. Is the air on? Just want to make sure. Now, this is the only reason why sometimes doing this under EOS guidance is an advantage. The reason being, I'm going to need you to hold this for me, sometimes already fluid's starting to drain out, right? And then you have a hard time seeing. And so I'm kind of pulling back. I'm looking for the white catheter. And just pulling back and looking for the white catheter. And it's just, there's all this fluid. And remember, there was also some debris and food up here. And this is the problem, that I'm having just a hard time seeing where I am.
Right.
So just give me a quick second to see. Trying to see, and this might be where I'll end up saying, you know what, we're just going to do this under EOS guidance, because I can't see the catheter well enough. But now I'm getting some air into the lumen. I still don't see the catheter, strangely enough. I don't know why. There it is. There is it there?
Well, there's a reflection down around 5
Yeah, I know,
o'clock.
because it's white, so it's kind of. I think it's there.
Yeah, I
Can
think
you
it
hold
is.
like this, please? Okay. Now what I'm going to do is I'm going to pull back on the sheet till I see a black mark. Okay. I'm still looking for that. I think the black mark's already there. Polly's already pointed out the black mark is already there. Therefore, I'm going to lock this again.
So which sheet are you locking the bottom of this?
Okay, the bottom, I've locked the sheath now, and then I'm unlocking to deploy the proximal part.
Can we just point out the radio opaque markers?
Yes.
Do you guys see the fluoro?
Oh, I see, yeah, so we'll look at the fluoral. Although, as I said, I never use fluoral for this, but you can.
It's just split screen.
You see the fluoro. So there'll be a marker on the stomach side and a marker on the cyst side, is that?
There actually aren't, but there is a marker, if I remember, I'm supposed to know this. There is a marker, I'm just not sure exactly where that marker is. And I guess I'm the one who all said, I don't want to have too many markers because I want the operator to really focus on the EOS view and then on the endoscopic and not get too distracted with fluoroscopy because you don't need it. I'm pulling back now and you're going to see the stent deploy. All right, there it's deployed. And look at the stuff coming out. Now this stent is hugging 2 walls, right? It's hugging the stomach wall and the cyst wall together. Look at that pus coming out. This, obviously those stents were not adequately draining this cavity.
Amazing. So
Now,
What are you trying to say, Ken?
well, I just want to say what we're going to do is we're going to leave the wire in there. Polly, we're going to leave the wire in there. We're going to pull out the device. We're going to dilate. Was this the 15 millimeter? Because it looks like a 10. Are you sure? Okay. You sure? Looks like a 10.
Nope, it's a 15.
Okay, good. All right. So we're going to leave the wire, and then I'm going to dilate this, and then we're going to go inside.
I'm sorry, it is the 10.
Oh, my Lord. Okay,
It was
so...
2 10s.
All right.
I was told there was one was a 15.
Okay, so I know it was a 10 because, you know, I can tell the difference immediately. So we really want to use 15s for this. You know, the 10s are for the gallbladder. So when we do a gallbladder later today, we'll use that one.
So Ken, listen, they're ready in another room. John,
Yeah.
Ken, this has been amazing for us. We're all in awe of this. It's fantastic. So we do want to come back, and we certainly will come back to see a little bit more. And we'll move over to the other room and hang in there.
Sounds great.
Thanks.
Okay, so I have dilated the lumen of the, in this case it was a 10 millimeter AXIOS, not a 15, but I've dilated it up to its full diameter. This is a diagnostic gastroscope. They don't have a pediatric gastroscope. So I'm going to see if I can get this through the AXIOS stent. It'll be a snug fit, but I think it's going to be okay because the stent is anchoring the position. So if you have the endoscopic image, you see the AXIOS stent right there?
Oh, we do.
Okay. It's kind of like the button of a peg or something. So now I'm kind of turning in like this. Still have a ton of stuff here.
Wow.
See? Look. Okay, and I'm going to see if I can maybe very gently wiggle my way through. It's going to be tough because the lumen's not ideal. You can look into the cyst, see it?
Oh, beautiful.
Yeah. Now, I don't know that there's a lot gained by my forcing it right deeply into the cyst. I think you can see that there's really not that much necrosis. It's really just more infected. And if you have a water pedal attached to this, we could irrigate it out a little bit and suck this out. Really all I want to do now is suck out some of this infected fluid and replace it with clean water. We could also put some dilute hydrogen peroxide inside. So if you have 3% hydrogen peroxide, dilute it 1 to 1, and then we'll put in 20 cc's of hydrogen peroxide. I have found that really works wonders. So now's our irrigation channel. And I'm just, I realize that you want me to push all the way through, but I would just hate to dislodge this for any reason, especially after I freshly got it. Oh, look at the stent there.
Yeah, we're catching gloves is great.
Yeah, so those are the stents. Now what would be actually very nice is to put a nasocystic catheter, if this is an inpatient, to put a nasocystic catheter through the port where you put the stent in, John, and then you would get a closed circuit irrigation, flushing of the stent. That would be kind of cool. So you're seeing your stents that you placed previously, and what I'm doing now is just sucking out some of this purulent fluid, and you're getting a nice look at the inside. All right, see, there's some necrosis back there.
So Ken, you're gauging against pushing it in by fluoro or just by the feel of the
No,
resistance?
just by the feel. I'm sure I can pop in.
Right.
The last thing I want to do is, push. I mean, there's not a good reason to go inside.
No,
Right? I'm not going to do necrosectomy now, and it's more just to show you that this would function as a port. Now, of course, with a 15 millimeter, no problem, right? I'd be in right away. But with the 10 millimeter, it's snug because the outer diameter of the scope is 10 millimeters.
Sure. So now let me ask you, if there's a lot of necrosis and you knew you had to do an necrosectomy, is there any reason to wait for this stent to sort of get...
No, that's the
So
reason. You can immediately start your necrosectomy without worrying about perforation and bleeding and all of that. So you do your dilation, aggressive dilation, right after you deploy your AXIOS stent.
Quickly tell us 2 or 3 devices for necrosectomy, and lastly,
My
what's the biggest
preferred one-
complication?
Okay, my preferred one is the Roth net basket. Obviously, you have to be cautious. You got to lay it out nicely over the necrotic area, press down, and then start to slowly close. Never dig the tip into any structure, so you have to make sure you can kind of land it over the necrotic pile. The other device I love is just put an EMR cap on the tip. It could be like from your band ligation, right? You used the cap there.
Yeah.
You can use that, go in there, suck the necroses, and just pull it right out, tease it out with a sort of torquey motion, and you can just tease that out. Now, obviously, when the stuff is like chewing gum, adherent to the wall, you're not going to get that out no matter what you use.
Now, is the snare verboten?
I personally think so, yes, because when you use EUS, you see all these vessels around, like the splenic artery and hepatic artery. and then you learn to really respect that this is a pseudo wall, right? You've got vessels sometimes right there in front of you. I've even gone in and used the mini probe and done EUS, and I'm amazed at how close the vessels are. So I urge caution, and that's why I think ideally we'd like to do this without doing any manual necrosectomy.
Right.
We'd like to just be able to flush out the necroses.
I think a tripod is also quite useful, I have to mention.
Good.
And while we were talking, Polly has gotten everything fixed up for us now. Now we can irrigate. So you'll see the water going in there, see? And so I call this vigorous irrigation. And just, filling the lumen up very aggressively. In fact, I tried, now this is CO2, right, John?
Yes.
Okay, never use air. If you have air, I wouldn't even go in the cyst, because that's where bad things happen. You can do it with CO2 gas, but I minimize the amount of gas you use. Because some of that gas, remember it's a pseudo wall, starts to track outside, then you got pneumoperitoneum and everyone's nervous, even though it's really benign. So what I do is I use water. And so it's kind of like my underwater colonoscopy. Well, this is underwater cystoscopy. So I just fill it with water and just irrigate and do the exchange until it's all nice and clean. So it's sort of like, following the principles of debridement. You really want to make sure the contents are clean and that they can flow out.
And you dump that without again in the end?
No, I don't. But I put the patient always on antibiotics before the procedure.
All right, I think we'll pop over to, is there any...
Hydrogen peroxide? Polly, come over here. She was just phenomenal. Everyone give Polly a big hand. It's just amazing.
All right, so your plan is to just give us a wrap-up plan, and then should we come back for more, or you're just going to leave the hydrogen peroxide?
I'm just going to put hydrogen peroxide and pull out, and I've discussed with John whether he wants me to put a nasocystic catheter in, although I don't think it's really necessary. It's just that you saw the stents, and so instead of a stent, you could have a nasocystic and use that for continuous irrigation, but I don't think it's necessary.
All right, if you do decide, let us know, because we'd love to see it. Otherwise, guys, amazing job, a great case. Thank you, thank you.
Thank you.